Hi, good evening, everyone. Thank you for joining us for a session at the Community Connect. We would be having a session addressing barriers to treatment and care, introducing the Mind TB project by Fode Boema. He is a partner in Health Sierra Leone. Mr. Fode Boema works as a monitoring and evaluation officer for Partners in Health in Sierra Leone. As a part of his role, he supervises and coordinates many of PHI's projects by providing data-driven programmatic support and coordination, including working closely with PHI's medical informatics team. Aside from the TB project, he has, for example, been leading the monitoring and evaluation work for nutritional programs for HIV and TB patients as well. He's been taking care of expansion strategy in the PIH's primary care projects throughout his project span. He is being employed and taking care of multi-pronged and adaptive approach to data-driven and human rights-based health interventions, constantly engaged in frontline workers with data and using data to support PHI's mission of providing preferential options for the poor in terms of healthcare. Fode has a diploma in computer studies and completed training in leadership and management in health at the University of Washington. And he's currently pursuing business administration from technology in Kiono, Sierra Leone. So I welcome Fode Boema. Fode, over to you.
Thank you very much. The Union Community Connect. I'm honored and privileged to be part of the 51st World Conference on Lungs Health. On this presentation, I will talk on addressing barriers to treatment and care, introducing the multi-pronged intervention for new diagnosis of TB, the Mind TB project. Background of the Mind TB project. The Mind TB project is being implemented by National TB Program, Stigma, and Partners in Health under funding from the TB Reach grant. Partners in Health is a social justice organization that believes in health as a human right and currently works in 11 countries, including Sierra Leone. The organization has focused on health system strengthening intervention. Please go back to the next slide. The next one, please. The organization has focused, the next slide, please. No, I'm still on the background. Go back one step. Go back one step. No, I mean, I'm still on the background. I'll definitely tell you to move on the slide once I'm done with each one. I continue. The organization has focused on health system strengthening intervention. So when PIH started supporting Sierra Leone during the Ebola epidemic in 2014, PIH focuses on clinical support across secondary and primary care, including maternal health, mental health, non-communicable diseases, malnutrition, HIV, and tuberculosis. Next slide, please. PIH utilizes 5 modules in implementing its programs, which includes staff. This encompasses on-a-job training, mentorship, training. The second one is staff. We ensure that we fill gaps, supplies, and reagents. Another module is space, ensure that there are 24 a day electricity supply and water, and as well infrastructure. We also ensure there are systems supporting referral quality improvement and communication systems. And the last module is social support. We ensure that we employed our community health workers and support our vulnerable patients. Next slide, please. Based on the non-digital health system intervention, we are able to support the national TB program to achieve 90% TB treatment success rate in Kono. Increase case notification approximately plus 200 from 2016, and approximately 50% presumptive patient referred by our community health workers. However, despite these non-digital health system intervention, we are able to support the national TB program to achieve, hello, can you go back to the next slide? Despite these health interventions, we are still missing 50% of cases in Kono district, especially among women and children. Next slide, please. For example, patients need to travel up to 5 hours on a motorbike on terrible roads to get to the next facility. Because of these experiences from Ebola, a lot of patients do not trust formal care provision and thus seek care from informal providers. Next slide, please. Our intervention or our response in addressing barriers to addressing treatment and care, as far as the Mind TB project is concerned, we recently launched and implemented 3 public health interventions in addressing barriers to treatment and care. One of the interventions we implemented was a community-based screening through informal providers. The second one is on a home-based sputum collection through community health workers. And the third one is improving diagnostic through gene expert testing and sputum referral throughout the district. However, while we believe that these interventions were necessary to reach more patients and address barriers to addressing treatment and care, we were worried about this diverse range of stakeholders, that is, facility, IPs, and CHWs, will be able to communicate and coordinate. Sputum and patient across the whole district. All those led to improving the coordination and communication to the TB care providers, thereby reducing the loss of TB cascade. So the 4th digital component, an adopted version of ComCare, allowing for tracking of patients across the TB care cascade, was meant to solve these. The next slide, please. Our intervention area, as far as the Mind TB project is concerned, of course, we operate in Kono district, a remote mining district, with a population size of 506,100 citizens, having 11 dots or diagnostic facilities with 2 gene expert machines, around 650 patients or 650 TB cases per year. Next slide, please. As I mentioned earlier, that we implemented 3 public health interventions in addressing the barriers to treatment and care. I would like to further go into the specificity of these different interventions. Engage community and private sector actors to increase TB screening and case detection. We collaborated with the Civil Society Movement Against Tuberculosis, a local civil society organization, and train and engage 79 informal providers to conduct screening and referrals, including infection prevention control. We developed and rolled out incentive structure for these informal providers so that they can be motivated in doing the job. We as well reviewed and share experience on challenges and progress made so far. Next slide, please. The second intervention was meant to reduce the barriers to diagnosis and improve case management throughout the district. We established specimen referral processes for community health workers, including supplies and reagents. We instituted a process of TB accompaniment and monitoring, and as well provide social support to vulnerable patients, and continue with community sensitization activities that includes the introduction of our operations to the chiefs within the communities. The third intervention was meant to strengthen facility-based TB case detection, and we implemented the WHO screening algorithm that focuses on diagnostic site within Kono district. We train health workers to ensure that these diagnostic sites are able to better care for patients and as well increase case detection rates. And we procured additional gene expert machines and reagents and laboratory supplies to these major dot site within the district. Next slide, please. The fourth intervention, in order to complement the three interventions, was meant to use technological innovations and gender sensitivity data collection system within the TB care cascade. We implemented a mobile-based application, ComCare, that allows data collection from a point of care that is from the community to the facility with geo and time tag. We monitor and analyze patient care cascade through operational research, including conducting a baseline survey. We use this data to identify patients that require additional support because we think it is necessary to follow up on patients. The pathways to addressing the barriers to treatment and care. A simple diagram focusing on the community intervention. We employed informal providers that screen patients within the communities using a paper-based form. Once a patient is presumptive, that patient is referred to the community health workers. The community health workers in turn enter the screening information into the ComCare and collect a sputum or either refer the patient through the facility for sputum collection and testing. If the patient is if they are collecting the sputum, they refer the sputum to the field supervisor. Then the field supervisor will then transport the sputum to the facility for testing. And once the patient is presumed is positive or is detected, then the patient will be called upon or will be traced to put on treatment. So the pathway here is demonstrating the community intervention where patient is screened within the community way through the facility for testing and treatment. Next slide, please. The impact of the MindTB project in addressing barriers to treatment and care. A total of 22,502 people were screened from July 2020 to September 2020 for TB within the communities and facility. Of those screened, 4% were presumptive and they were tested. 22% were diagnosed for TB, And of those diagnosed of TB, around 90% and above were put on treatment or started treatment. Our initial finding considerably state that more female presumptive for TB in the community than in the facility. And initial findings suggest that 50% for community screening are around, 50% are community screening and 30% are facility-based screening. And this is largely driven by our caregivers, who majority of clients are women. Next slide, please. There have been numerous challenges as we implement the Mind TB project. Given the social stigma attached to COVID-19, as COVID had related symptoms to TB screening, community members have been reluctant to partake in the TB screening. The CHW staffs have been a little bit stretched because of the COVID activities, making them having more work to do and regularly focusing on COVID intervention. Informal providers have limited educational background, and sometimes there are challenges in data collection processes. Next slide, please. Our next step is to increase and reinforce contact tracing activity throughout the districts. We'll continue to roll out the TB screening at all points of care, at all diagnostic sites within Kono districts. We'll continue with case detection activities, including home-based sputum collection through the community health workers and a house-to-house screening in collaboration with informal providers. We'll continue to provide refresher trainings, field visits, and on-a-job mentorship, since there is a need to provide accurate and quality data to better inform our programs. Next slide. Thank you all. I appreciate your kind audience. God bless you.
So hi everyone, thank you so much for being there on Community Connect. As Fode has just shared his presentation with us. In case if you have any questions, I would request you to write in Q&A, or maybe you can raise your hand so that we can allow you to ask it directly from Fode. But maybe would you like to share any experience that you've had during this entire time when the nation was trying to fight COVID, and how did you work simultaneously on COVID as well as tuberculosis? Would you like to share some experience? Since we don't have any questions from the audience, would you like to share something?
Yeah, definitely. So
I
yes,
think we have a question from Oil she says, good afternoon. How have you been able to deal with the stigma associated with COVID to encourage uptake of TB testing?
Yes, so thank you very much. So yes, it has been difficult really because COVID and TB has related symptoms, and this was a great impediment to the Mind TB project. We implemented different strategies to ensure we combat the stigma around COVID-19 as it had related symptoms. One of it was to employ social mobilizers. These social mobilizers were, their role was basically to go to these different facilities, go to these different communities and ensure they talk to people and see the need of being screened for TB, as even though they have related symptoms, but it doesn't mean that if you are screened for TB, mean that you have COVID-19. So we employ social mobilizers to talk to people within the community, and we enforce or reinforce the community sensitization to see the need of no fear of COVID-19 to that of like TB. So basically, our intervention was more focused on community sensitization, like telling the people within the communities the need of not being reluctant to TB testing or TB screening. Yeah. I don't know if that answers the question's question.
Right. So I think maybe we can take another question that has come from Mavis. And he says that thank you for the presentation. So, what group of people were considered as the informal group?
So we have traditional healers as one kind of group of people we consider informal providers. We have caregivers. These caregivers are like people within the community that we think are notable people, more especially among women. And as well, we have drugstore, like those who has like this little pharmacy within the communities, like a drugstore within the communities. So these are like the three categories of people we consider as informal providers.
Right. So, if we have any more questions, maybe you can share in the Q&A section. Or would you like to share any question or any experience with the audience attendees over here for today?
Yes, definitely. So part of my presentation, I talked around the three public health intervention. And honestly, it has been working very well for us. You know, we've been able to realize that if you uses traditional healers, drugstore, and as well caregivers that are within the communities, it could better improve uh, TB screening, because a lot of our community people do believe that when they start coughing or when they have cough, it could be related to uh, demonic affairs, or it could be related to something that has to do with demons. So they run straight to those traditional healers without knowing that it is TB, without knowing that it could potentially be tuberculosis. So using the informal providers for TB intervention could better improve the case detection rate, and as well encourage the process of detecting TB as quick as possible. And as well, the process of home-based sputum collection, I think it is actually new in so many countries, wherein you have community health workers undertaking sputum collection and refer the sputum to the facility for testing. I think all of these strategies have yielded benefits to increasing the case detection rate and reducing the barriers to diagnostic and TB treatment within the communities.
Great. So maybe would you like to comment on like how when the COVID is there, you were able to actually still go for active case detection, and did it affect the entire process? Would you like to throw some light on that?
Yes, it do affect the entire process when uh, the COVID surfaced in Sierra Leone, because a lot of stigma was attached to it, and taking to the background of Sierra Leone having experienced Ebola before. So the issue of stigmatization has been the order of the day. So when COVID surfaced or resurfaced in Sierra Leone, there was like a lot of challenges, but we intensify community sensitization. We employed.
Fode, I think we have lost you. Are you there? Fode?
In general, we were able to intensify our
Oh,
community sensitization.
actually, we lost you in between. So maybe could you repeat that? I'm so sorry about that.
So I said, when COVID surfaced in Sierra Leone, we experienced a huge problem with the Mind TB project, but we were able to catch up and strategize our approach by putting more premium to community sensitization, thereby employing social mobilizers. And the social mobilizers, we are going house to house, sensitizing community on the need for them not to be reluctant to COVID, to TB screening. So we were like explaining the need for them not to fear. We are explaining the need for them to see that COVID, even though it has a related symptom, but we are still missing 50% of TB cases within the community. And there was a need to actually like go out and do case detection using community sensitization and breaking the chain of stigmatization within the community.
Right, that's great to know. Is there any specific advocacy efforts that you're doing, like during these times?
Well, one of the advocacy that we are doing at this moment is to ensure that we increase, we have like a gene expert cartridges that we could use to increase case detection rate in Kono district. And we liaise a lot with national to provide gene expert cartridges so that they are used to increase case detection rate within the districts, more especially for cases that we think we could further detect using gene experts. And as well, supporting patients, vulnerable patients, more especially like those that could not afford to get food, and as well some basic amenities. We are also advocating to provide them with basic amenities to better improve treatment outcome.
That sounds great. So I would again request our attendees if they would like to share anything or would ask any question. I mean, they can raise their hand so that we can connect you to Fode to have a discussion. All right. I think we do not have any questions. So, like, would you like to sum it up and the entire session and probably share something with our attendees? Some message that you would like to give?
So one of the key messages I would love to share with the team or with the audience, it is better, good at times to look at different strategies, look at different implementation pathways in TB care, as the way we did here in Sierra Leone. We employed these 3 public health interventions that we think could better increase or improve case detection rate and reduce the barriers to TB treatment and care. So I will encourage other countries or other partners or other TB implementation group to use the model of the informal providers, the community based, the home-based sputum collection approach, and as well the technological approach that could better develop or increase the data collection system, because knowing the fact that we have a screening that is happening in the community way through the facility, we definitely need an improved technological approach to better collect the data and get an informed decision around our TB activities. So I will encourage the team to use this 3 approach as far as TB care is concerned. And I think using this approach will better increase case detection within the community.
Right. So that's a very powerful message. And on that note, I would like to thank everybody to join, whosoever has joined the Community Connect session. And thank you, Fore, for delivering such a powerful session. And I think we'll be closing our session since we do not have any questions. So thank you so much.
Thank you.